just us, and we'll catch up. We're just doing skin. We're going to start skin today. We'll have it surely all done Monday, if not, and probably more in the lecture than in. Everybody likes Dr. Dress, not me, and we'll get that all done in lecture, and maybe have a little overlap in the lab because I want to dedicate the lab to bones. It's going to be know your bones, pick up your bones, hold your bones, and start to work on. And I'm going to try to get through the axial skeleton, which is so there'll be a lot to accomplish, but at the very least through the skull, which is the hardest part. I always like to get the hardest part out of the way first, because you need hands-on stuff, because it takes a little while before we get to the dissections. I'd like to sooner I can get through the bone and joint stuff and it's very topical because of early season sports. There's so many injuries and things like that. Without further, so we're using this one. And again, I'll come back and take a look and see if the Welsh Hall PowerPoint has anything else. This is the one that's on there. This is the Chapter 5, the integumentary system. It's Chapter 6 in the Welsh Hall textbook, if you happen to use that or you got the book bundle, just to acquaint you. Same. The skin hasn't changed dramatically. Sometimes the names have that are there. Voila. So integumentary system. So today we're really focused on the skin, and inevitably do what we call skin appendages like hair and nails subsequent to that. That's the second half of the presentation. And you might have had some of this before. I do not know. But I like to do it my way so you really get into it. It's one of the areas I'm very, very so much. You don't flatter yourself by thinking you're good at something, but I was pretty good at dermatology. I had a lot. I did a lot of dermatology with bacterial and fungal and viral infections. A lot of dermatological surgery. Okay, I did a fair amount of skin grafting. So those are. I hope to have a little. I'm just trying to acquaint you with I have an area that I consider somewhat of an expertise. I try to stay away from the hair part. We minimize that because I have minimal hair. At least Jennifer smiled. Got a chuckle out of her. The rest of you, the poster on my door? Spaceballs, the movie. You ever see the movie? Don't know what you're missing. They're going to reboot it. Mel Brooks, 99 years old. He's going to contribute to. I'll be in tears, because that ship eventually sails. My wife's mom rather, died in February at 98 and a half. She had a really good run. She was living independently. I would dare say till 94, 95, and only went into a nursing home in the last 6 months, let's say. Some people they're there for a long time. Nevertheless, skin. Here it is. Skin, hair, nails. By definition, we revisit glands and get in a little bit more detail about sweat and sebaceous glands, but it's really the same stuff we cover. So it's not a big deal. So again, it's 3 layers. Traditionally, when I learned about skin, at that point, they considered the fatty layer called subcutaneous or hypodermis, as they talk about here, as part of the skin. It is not. Okay, this is what we call superficial fascia. This is a surgical term or a surgically inspired term. When a surgeon makes an incision in skin, okay, that incision, if it's good, carries down to fascia. And you will know that because when you get through the dermis, it's almost like it opens up magically. And it's in that fascia where the significant nerves and blood vessels are that have to be identified and retracted, moved away, or cauterized or tied off, depending on the kind of procedure that you're doing. So it's in that. So that's really, when you're getting it right. It's not easy to make a cut in somebody and get it exactly the level that you want it to. So the epidermis, now it's just the epidermis and 2 layers of the dermis. We have the epidermis, which is superficial to the surface, and it's epithelial tissue, stratified squamous, keratinizing. Because this is the one where it moves away from its blood supply, it dies. By doing so, dying, it begins to change, and eventually then becomes really the magic of skin, is now you have a very hard barrier that is remarkably difficult to puncture, as I just said, difficult to cut through, watertight, all of those neat things that are there, providing a great area of protection, an area where bacteria can come on and protect you, your surface bacteria, which we're entirely covered in. It's great. Okay, underneath that are two layers of dermis. Okay, is the larger amount of it is a dense, irregular, fibrous connective tissue called deep dermis. That's the strong part of your skin. When you hear about somebody making leather, okay, from animal hides, that's the part of the skin that it's coming from. That's where the tanning and things like that. And a thinner layer that is more vascular, which is, again, everything that underlies epidermis. An epithelial layer is always the first layer that's underneath this, because it provides the blood supply, bless you, is superficial, loose areolar connective tissue. It's loose areolar connective tissue. It's about 80-20. 80 deep dermis, 20 superficial dermis. We'll get to that. So the sub-Q is just that. It's more of an anchoring layer. A little bit. It adds a lot to the skin. Really, it's where the center and the blood vessels come from, they emanate from, and they're able to get into the skin. Shock absorbs, insulates. It has all this is true. This is the classic illustration. The first thing to notice, okay, is here. It is not, when you think of the epidermis, and you can see how thick the dermis is, and about here would be, from here to here would be the superficial dermis. And here you get the bulk of the deep dermis, which is strong. We anchor hair follicles, we anchor sweat glands, we have special sensors that will review when we look at signs of nerves. It's the hair follicle, the only muscle that's attached to it, the erector pili, which makes your hair stand on end, goosebumps, goose flesh, whatever you want to call it. Okay, all of those effectively are in the deeper area. But look here, you would not, it's not like one layer on the other. You can see it's ridged and pegged. Biologically, when you get a blister from a new pair of shoes or from something, a sport that you're doing, oh man, I got a blister, I was running, maybe it was my shoes, I had something in my socks. Basically, it's skin layers doing this. They separate easily. What keeps them from separating is folded, it's fan folded. That increases the surface area, there's greater contact. That's where form and function come together. And it's in two directions. It's not just one, it's not just going, let's say, vertically, it's going hard, it's going east-west, it's going north-south. You can see these rich, and they're very important. You will find that the genetic pattern of these things creates something that identifies us, fingerprints. See? Good stuff. And you can see it's not completely, because there are openings. Hair follicles are opening. A lot of infections get in through hair follicles. Okay? There's also openings for these sweat pores. Those are little pores. They're exit points. Anything that's an opening, so stuff can get into. So, but normally your strongest barrier to infectious disease, your skin, period. Nothing is stronger than that. That's why if you're going into a medical field, your skin is so. When you're a resident, particularly if you're going to be a surgical resident, all you want to do is you want to get your chance to operate. The orthopedic surgeons at our hospital, who are royal paid, old school royal paid in the ass. We'd have before, if we were in their OR, they say, let me see your hands. And they expect your hands to make sure you didn't have any nicks or cuts. Because not only are you more prone to infection, you make the patient more prone to it. Okay, I don't know where you got that. You're not scrubbing it. You're gonna be the runner. You're running to the ER. You're running to the X-ray. You're running with it. You're writing orders. You learned early on, bless you again, that it was that your hands, you didn't want anything bad to happen to them. Just to give you an idea. So you can see the relative thickness is there, and then we'll get into the deeper structures. Notice, you can see, I mean, it's written this way for effect. This is where the blood vessels are significant. That's when people get a cut that really starts to bleed, you're down to this level. And so we'll get into all of that stuff. So the fancy names, other than the epidermis, papillary, because these are called papilla. These hills and valleys, okay, any way you want, the ridges and pegs. And we see a lot of that sort of repeated itself, all about structural changes that facilitate increased amounts of surface area. So we make more surface area. There'll be tons and tons of these as we go through the anatomy. Then you have the papillary dermis, which is the vascular, and then the reticular or deep dermis, which is very avascular. So you already should be able to see anatomically the reason why something scars. If you get a cut and it's just down to here, it's going to heal. It'll bleed. There's little blood vessels. But as long as it doesn't get into that deep dermis, it's not going to leave a scar. So when you make a surgical incision, it's going all the way through it. It's going to have a scar. That's the difference between what gets burns are part of this chapter. Skin cancer. I used to think it was 1 out of 5. Now they're looking almost like 1 out of 4. And someone getting cancer doesn't mean the severity of the diagnosis. An article I read recently, 1 out of 3 of us statistically now. Most of it's skin cancer from our exposure to skin. I don't want to get started on sunscreens. They're not necessarily all great. Like a lot of the pharmaceutical industry, they sell us a bill of goods. Okay, but as we move on, all of this is where it all becomes relevant in the context of what we're doing here. Okay, so the epidermis, keratinizing, stratified squamous, 4 cells to remember. Keratinocytes, depending hereditarily, genetically, 75 to 90% of these cells are keratinocytes. They are making the keratin that's going to eventually make that outer layer. They're the ones that die and go all the way to the top. So, and you can see effectively that protein starts to manifest itself as it gets somewhat far away from the blood supply. Okay, that is the major cell. Very strong. Desmosomes, the strongest intracellular bond. You guys already know that. Okay? We lose, as you can see, millions every day. If you have an older relative, particularly in the winter, you see winter dry skin. If you live in the Northeast, if you work with older patients or older folks, take off their socks, you see that powder on their socks. It's not white powder, it's skin cells. All the time. By the same token, 10 to 25% are the pigment cells. They're called melanocytes. The pigment they make, it bears their name, it's called melanin. So they are, when they say spider shape, basically they have star-shaped or tentacle-like projections, in which they invades the wrong term. They're in contact with the base cells, the keratinocytes, and as they secrete these granules of melanin, they become incorporated in the keratinocytes and they provide us with pigment. Your coloration is not so much the number of those cells, because the number is fairly consistent genetically. There's variations. Okay, it's how active they are. So when you see something with albinism, and I mean, you're having genetics now, if you didn't get to that, you're going to get to that. That's a genetic defect. That's there, typically the hereditary albinism we see. And we mostly see it in people of color more than anything else. It means an inability to produce the melanin. It's active, but you're missing an enzyme in the tree. So the cell's activity does not produce the melanin, but they remain active. So it may be a funny way to explain it. Ask Dr. in your genetics class. But nevertheless, that is the activity. People get worried because if you're of color, you're very, very dark skinned. It doesn't mean you have more, it means they're more active. It really is a better way to look at it. And then we have a true star-shaped seed, dendritic, think tree branches, white blood cells, dendritic. Langerhans cells are a variation of white blood cells. If you had immunology, maybe you talked about them with Dr. Maurer. Whenever you have a barrier with the outside, whether it's in your gut, whether it's somewhere else or in your skin, it's constantly sampling the environment. It's like your immune system's like any other system. You got to keep using it. And so these little tentacle-like things are sampling. Oh, that's normal. That's normal. Whoa! That type of stuff. And so they're always there. You have a ton of them in your liver. They're called Kupfer, Kupfer cells. Get to the liver. They have different names. They're really important. They're like, we call them APCs, antigen presenting cells. And immune, we'll get to that. That's physiology. For those of you who could stand me for another semester. That's right. I don't even like it that much. What are you going to do with you? Glad you're sitting by yourself. And Merkel cells. These are on the tips of nerve endings. They're modified epithelial cells. They don't really get replaced per se. Same thing with the melanocytes. You make more of them, but they're not replaced as rapidly as the keratinocytes. They are very much for soft touch. In areas where they're concentrated, you have a lot of soft touch. You all know this. You have your nerves are so concentrated in certain areas. You can tell exactly when something gets on your face. If there's something here, do I have an eyelash here? Do I have this here? Is there a hair here? You know that. Or if it's on your back, it's on my back. I don't know. That's because you have an abundance of these in certain areas. The more sensitive the area, the more abundant these so-called tactile cells are. 4 or 5 layers. We see the 5th layer in thick skin, typically palms and soles, and occasionally, the lumbar area of the back, because your skin is quite thick. And we call them strata for layers. That's all the word layers are. And there are 5. All of this you have to know. The stratum basal or base layer, sometimes called historically the stratum germinativum, because they germinate. These cells are where things germinate or grow from. As they begin to grow away, they name this layer, and I am one of the many who it is somewhat of an optical illusion. I beg your pardon, not illusion. That I'm losing my voice as we get to the end of the week. That causes a spiny appearance. We're not sure. A lot of things, and this is where we get to artifactual. I mentioned that before. When you stain something, when you're taking a piece of skin, it's dead. You're putting stain into it, you're preserving it. A lot of times what's there isn't necessarily there. But we name it for what we can visualize under the microscope. So that's the spiny layer, because it has this spiny appearance. It has nothing to do with the philosopher Spinoza. Philosophy? Is that name ringing a bell? See, I'm doing this. Back in the day, when you had a core, you had to take like philosophy, sociology, and psychology. Which we call they were a snoozer to us. And we didn't have the luxury of hiding behind those laptops or watching replays of whatever you want to watch. And then as it grows farther away, now it begins to die. And what happens, you see it is highlighted as the nuclei flatten, and you begin to see the appearance of granules. They'll name them here, called keratohyalin granules. They are the precursor to keratin. That's the transition. Okay, you will see. And then in the thicker skin, and it's a layer. They think lucidum means clear. It's a clear layer. It's not that the layer disappeared. Erroneously, people say, "Well, it looks like there's no layer there." It doesn't stay. So that's why it's a clear layer. You see it on palms and soles all the time. And then the most generous of all these layers, depending on the author, I was taught 30 to 40 layers of cells that have died. They're filled with keratin. So it's keratin and membranes. So it's something that has structural strength, and the membrane is fats. So you have a fatty layer that's also protective. So that's why your skin, when you have somebody with a smoker's patch, when someone who's getting a nitro patch, okay, skin is a wonderful way to administer medication because it's easy to predict the rate of how fast it's absorbed. But it has to be medicines that are fat soluble. That's why like Nicoderm patches work. Nicoderm gum doesn't work from swallowing it. So all the blood vessels in your mouth is absorbed directly through that. You did not know that. They're called occlusive dressings. I used to use them in my practice all the time. You put them on, you basically limit the amount of air and rely on moisture and allow on that absorption. And again, it's very, very predictable. Fentanyl patches are very famous for people with end-stage cancer. So it's a steady flow of a very, very powerful narcotic. They weren't around. We didn't have fentanyl around. Only it was in sort of in its infancy as a therapeutic. There's a whole other discussion about that. So a base layer, deepest of all the epidermal layers, you're down there. Okay, firmly attached to the dermis. I'll buy that. Consists of a single row, and these are a stem kind of a cell. Everything sprouts from them, and they're very actively mitotic. And again, what happens is when in mitosis, it's basically lifting up the pyramid. It's like you're building a pyramid layer by layer, and rather than putting it on top, you're putting it in the bottom. So it's moving away from its blood supply. The base layer becomes the next layer up, and so on and so on. That's how it moves away from its blood supply. So it's some people, to me, it's intuitive. Some people find that you have to just reinforce that. Average time about 30 days. Okay, the daughter cell to the surface, and that cell dies as it moves to the surface. For instance, you hear about people with psoriasis. One of the things which is autoimmune in nature. Some of the things that psoriasis does is it moves too rapidly. What happens is you see effectively when you rub those things, little bits of skin cells come off. They're not, and you see pinpoint bleeding. It's one of the tells. We're trying to make that diagnosis. It's got a fancy name. And people going into medicine, you learn all those names called Auspitz sign. They're like me. I love names like that. You don't have to know it, but I'm trying to give you some context. This is what it tells us. We know the skin is growing too rapidly. Some people have lichenification. Lichen means leather-like. Okay, and that means their skin is growing so slowly. I mean, it's thick, and it's really not shredding off at an appropriate rate. So that's where it's leather-like skin. A lot of people get that from being exposed to the sun. Well, have you ever seen somebody who's had it? Oh, it's awful. This lady we knew, strikingly attractive, well into her 50s, and we'd see her where we lived. There was a lake up in Venango County. It's nowhere near a beach, so they had like a lake in one of the county parks. And all she would do is throw cold water, sit out there, in a relatively skimpy bed, and she was absolutely bronzed. As time went on, that was not a good look for a strikingly attractive woman. Yeah. So the cells die. Only the daughter cell remains as the stem, stratum germinativum, 10 to 25% of the layer, melanocytes. Okay, the melanocytes, when we get to the area on pigmentation, they're releasing that pigment, and even though they stay in the base, the pigment gets absorbed by the cells as they move away. The spinosum is not single, several layers. I'm not going to ask you the number. And what they say is because it's starting to form the filaments, and the filaments are attached. This is the science behind it. I still think it's more optical illusion. What they're proposing here is that as it moves away, it's starting to form a precursor, and they're attached to where the desmosomes are. So it's kind of like if you have something that's flexible, and I always have something in my pocket that's flexible. As you pull it, it gets sharp points. I don't leave home without it. So if you're pulling it away and it's attached, you get that kind of pointy stuff. You have a poop bag in your purse, don't you? You don't have a dog. Would you like a dog? I have a very big dog. Oh, you live in a dorm? Oh, you can't have the dog. He'd stick out. He'd love to be there. Just tell him he's a fixed boy. So 74 pounds. So prickle cells scattered among the keratinocytes, and then you have the melanosomes, and you'll see it when we get to the layers. So I don't necessarily buy it. I think it's an optical illusion. It has to do with the fact that it's deceased, and so to me, are the cells attached? For sure. Okay, everybody has an explanation. Now is when it's really starting to go. The cells and the nucleus. Remember, we describe cells. The shape of the nucleus often mirrors the shape of the cell and where it's located. Cells flatten. The organelles when it starts to deteriorate, it's starting to die. Nucleus is there, not dead. Keratohyalin granules that eventually lead to the keratin fibers. other granules, and you can see you're eventually going, I mean, you're starting to develop this significant glycolipid component that plays a significant role externally. Okay, and after that, that's the last layer where they are contain a nucleus and therefore viable. That's why if you get skin, that's kind of dead skin, you're not going to be able to get DNA extraction. That's all reliable from that. Just doesn't. You're going to have some lives, maybe a hair follicle will help you. And so they're too far away from the capillaries to survive. The lucidum, it's not a translucent band. It just doesn't stain. I mean, you can call it what you want. Clear. I don't know that they're clear. They just don't hold the stain. I mean, living things, bacteria are, relative to us, they're clear. How do we see them? We stain them. Okay. And superficial is a granulosum. And they have 20 to 30 in this book, 30 to 40. 30 would probably be a good number. 3/4 of the thickness. Protection, water loss, strong abrasion and penetration. Barrier, we talk about this in immune. They're a biological barrier. They're covered in microorganisms. They're a chemical barrier. As the cells break down, as membranes break down, okay, you end up with acids. Remember what happens, basically it's an acidic environment from fatty acids that are involved, the long chain fatty acids. Acids are acids, an acid mantle, we call it. It's covered in perspiration, which is salt. Bacteria don't like salt. Staph likes salt. That's what we do. Remember that MSA, that agar and micro? That's what you use. You use 7% salt agar because bacteria don't like salt. Salt's how we preserve things by not allowing them to get bacteria for the most part. Like salted meats or salt, you probably heard this one. It's the derivation of the word salary. It comes from salt. They played the Roman soldiers in salt so they could preserve vegetables and meats. See? Learn something new every day. So the expression, he's not worth his salt. And if they were bad, they went to the salt mines. Is history part of the core here? And so, they're undergoing apoptosis, dandruff. I'd like to shed more. I could lose weight. Here's what it actually looks like. That's the top of one of those that I described to you. One of these papilla, one of these sort of jutting out pegs that fit. So you have pegs, and this is the ridge per se, and it fits in. The ridge is here, the peg is here, blood vessels are here. So that's part of the vascular or superficial dermis, loose areolar connective tissue. You can't see it as well. The cells start mostly cuboidal or columnar. As they begin to move away, that's the spiny layer. They're flattening out here. Okay, and now you have this multiple thick layers we don't see in nuclei. Better seen here. As you can see, now they're flattening out. That's the granulosum. It's not a great illustration. Here, you can see one of those. We begin to see the cells that are there. Here you can see the dendritic cell here. You can see melanocytes here, which they've drawn pigmentally, adding a different distinctive color to see and picking up the granules that are there. Here's that Merkel or tactile cell. Interestingly, certain kinds of skin cancer come from that. There is a Merkel cell carcinoma. It's a pretty nasty skin cancer. The worst cancer we'll get to is called malignant melanoma. That's the pigment cell cancer. But if you remember Jimmy Buffett, the composer, Margaritaville, Key West, all that kind. He died of one of those cancer of one of those Merkel cell carcinomas. If you get there, Key West is fun. And then chickens. Chickens are free to roam. They were freed because they used to cockfight. My wife and I just absolutely loved it. Some people are annoyed by, we love the chickens. There's a fine if you hurt a chicken. Plus, there's other attractions there as well, but we digress. We actually, when we stayed there, we stayed in forgive me, in a wonderful bed and breakfast that happened to be in a former life was a bordello. Okay. For those want, I'll get you the name of it if you want. Angelina's Guest House. It's gorgeous. It's gorgeous. So the rooms were used for other purposes. Oh God, we had a great time. So the derm is strong and flexible. Everything's in there. It's a microcosm of your cellular elements. Connective tissue isn't just fibroblasts making fibers and ground substance, okay? It's everything. You have all different kinds of white blood cells that are there. A lot of, not, it depends on the area of the skin. I mean, wherever, if somebody develops hives and things like that, or gets rashes very easily as an allergic response, that's where you see a concentration of mast cells, all of these types of things that are there. The fibers in the matrix, and again, it's in the deeper dermis. That's where they make leather, nerves, blood vessels, lymphatics, epidermal hair follicles, sweat glands, sebaceous glands, papillary, the ridges and pegs, and that is a very good example. So they call these dermal papilla. This is, you can see the dent here, you can see in dark the fibers here. You don't see the abundance of fibers, visible abundance, even though there are fibers. And that's why even though the epidermis is avascular, here's epidermis. And you can see it if you just, it doesn't, you can't think flat. It's coming from here and here, all the germinative cells. You can see the flat nuclei here, and voila, all of a sudden we're at epidermis. Now you can tell this is not a palm or a sole or a similar area with thick skin because we see the transition. We don't see that clear layer interspersed. You could Google and find micrographs of the other fairly easily. So the superficial, loose connective tissue, loose areola, by definition, you're going to find fat cells in there. When we accumulate fat, that's the layer it accumulates in first, more than any other. And again, women and men in different areas that are there. Interlacing collagen, elastic, and elasticity is part of it, as you will see. I mean, your skin can do this. There's snap. It has to do with water content. The fancy name for this turgor. When you're examining a patient who's dehydrated, you can pick that up. Normally, you and I will snap right back down. But if someone's dehydrated, that'll stay there for a while. And you learn how to grade that. Now, sometimes with your skin, an elderly person, you can't do it because they may be dehydrated, the skin is bound down. And you learn to tell with edema if there's too much fluid. So, skin is a wonderful indicator. Temperature, circulation, all of those things. If hair is growing and all of a sudden it disappears, that's bad. Having hair you don't have to have hair in certain areas hereditarily. You'll get that. You know, not everybody has hair. They may have it here, but on that second area, I mean, it's one of those hereditary things, dominant, recessive, all that deal. But if you had it and now it disappears, well, now all of a sudden circulation may be compromised. Everything you learn tells you something. So the superficial derma, finger-like projections, tactile corpuscles that are there. Meissner's corpuscles are a little different. They're within the superficial dermis. You'll see another one. We get to special sensors. I'll remind you about that. As you saw in that initial diagram called Pacinian corpuscles. They're sort of round. They're for deeper sensation, vibration. Each sense has a different kind of receptor defined by shape. I'm not going to ask you to identify those. But depending on where you're going to a graduate program. So the dermal papillae lie on top of the dermal ridges, which are epidermal or friction ridges. We can grip, we can touch, we have sweat pores. That's where fingerprints come from. What makes them unique is how you are genetically coded, these fingerprints. And basically when you see them, you know, they're be able to, with whatever means are used technologically, just use powder, they're able to extract those fingerprints and marry them for that unique signature that's there. And so here's where they are. These friction ridges and the little sweat ducts that are around along the crest help make the fingerprints. I don't know anything about them, how they're, you know, certain kinds of patterns have certain kinds of identification, but that's where they are. The reticular layer, 80%, 80-20. That's tough. Coarse, dense, irregular, lots of elastic fiber. So now, rather than just lifting up the skin, I mean, you get the recoil. That's part of it. That's all part of ways to look at see. My skin doesn't do it the same way. My skin's much thinner. I had that. It's finally going away. My wife said it looks like it was a tick bite because it had that special, the pattern that we see with Lyme disease. It does. It was. I mean, I know what happened when I did it. It's just your skin changes. You get older. It just you lose subcutaneous fat. It doesn't have the resiliency. It tears more easily. So you can only if you avoid aging, you can avoid that. However, we have not figured that out yet. So stretch, recoil, collagen fibers provide strength and resiliency, bind water, keep it hydrated. All of that's all true. Okay. Blood vessels between the reticular layer, as I pointed out to you, underneath it, and then the hypodermis. And those layers, those were the big nerves that eventually penetrate the large vessels. They don't really give blood supply to that layer. They just traverse it to bring it to the superficial layer. Okay, and yeah, adipose cells are there. And this is where you go tension lines. In the reticular layer, these collagen fibers running parallel, you can't see them. These we call them, these are, some surgeons will call them the lines of relaxed skin tension. When you're doing a surgical incision, you plan. Sometimes you don't have a choice. There's a big tumor here, you got to cut over it and you open it up. You want access. But most of the time, if you do a joint surgery, now if you're doing a knee replacement, you need exposure, you do it like this. But if you, in the old days, before we had basically being able to do arthroscopic surgery, when we had to enter a knee, we came down this way, we went across and went that way. And you literally took a clamp and pulled it aside. That way you could see inside the joint and you sewed together. Appreciate ligament. I mean, it wasn't scientific, it's 50 years ago. We didn't have that technology. It's in its infancy. The same thing when you're putting in a hip fracture, you might go right over it for access. But if you're putting in a new hip, you're going to try to use these lines. They heal better. You can see them on the arm. It's there. And the way you can find them, they're natural. So if you pinch like this, those little flesh are very, if you do it like this, you don't see them. So that's where you can find, and that's how you incorporate them for plastic surgery, particularly on the face. And these plastic surgeons are very well skilled. These kinds of things. So I mean, it's not just, oh, this is the easiest way to get there. Particularly with elective surgeries and cosmetic, or cosmesis, fancy term, where the cosmetic aspects are important that are there. Sometimes it's not avoidable, and they have them here. So I mean, this gives you a little bit of the idea. This is what you do when you take surgery classes. This is kind of something. It's kind of stuff they school you about. If you're a resident, and then the attending will say, okay, discuss historically the incisions that are usually used. And they actually have the techniques, and different incisions have names. So what it means is, just like you should for anything that you're going to do professionally, do your homework if you can beforehand. You're going to go in, I know I have this patient or that patient, study about it. Someone's going to start asking you questions. It's good to have an occasional answer. They will hammer you if you don't. So these are different. So when these flexure lines are about usage. So when someone goes for a palm reading, and people have fun doing that, and some people think it really tells them, the folks who are doing it know what they're talking. They can tell whether you're doing physical work or not physical work. Certain time lines reflect certain events or certain things that have happened. Okay, and they're visible, particularly in this. So you can find where they are, and so there's different characteristics about usage, so they tell people something. It's very interesting. So there's more to it. I don't know if they're probably still doing it. The two Vegas guys have always been involved with that, about pointing out fakers, are Penn and Teller. Penn and Teller, they even show you how they do a lot of their magic tricks. They have a theater that's built for them in the Rio in Vegas. And they're there, maybe 2/3, half the days of the year. Sometimes it's dark. And I've been to see them twice, and it's just fascinating. And the first one, they come on up on the stage, figure out how we do this. Figure out how somebody gets out of the box. The magic, stuff somebody in the box, and they're not there. It shows you exactly how they do it. Wild. And they show all this kind of stuff. It's just so wild because they've over the years they've tried to debunk a lot of people. So, and that when we stretch the skin, it tears. So, if somebody's very heavy, they get those. After pregnancy, they call them stretch marks. There's nothing unusual about them. And again, here's the blisters. Blisters are separated at the dermal epidermal junction. That's why when you get a first degree burn, it's just the epidermis. It may be unpleasant. It's not harmful. Once you get to that next layer, the second degree, and these are what we call partial thickness. At that point, now you're getting that fluid. If you have enough of those, you lose a substantial amount. The big problems with burns are two. They're 1 and 1A. To me, they're equivalent. Fluid and electrolyte loss, infection. Burn tissue is comfort food for certain bacteria. One you work with in the lab, Pseudomonas aeruginosa. Remember that in the lab? Yes? Kind of turned green on the plate, thinking about. So Pseudomonas is the bane of existence of a lot of people in a hospital. It's everywhere. That's why they don't want you bringing in fresh plants because it's in soil. It's on your shoes. It's normal on your skin. Nasty. Very hard to find antibiotics for that. Very difficult. And most of them have a lot of side effects. You don't have a magical pill so much for that. So that's blisters or stretch marks. And now we get to the pigment part of the program. It's made by melanocytes. That's the skin pigment. We have other pigments that affect it. Okay, things that impart color to our skin are not only melanin. The hemoglobin does. It's like your fingers. I mean, if you take your finger and squeeze it, and you let go of it, it's white, and it fills up right away. It pinks back up. You're testing the circulation. Nails, same way. Squeeze it, let it go. I do this all the time. You have an idea of how long it takes to fill, how long the color comes. It should be almost instantaneously. That's because the pigmentation, particularly under the nail, has to do with blood flow to the area under the nail. I mean, if you're sitting there, a diabetic, and you lift their foot up, and you do this, and you're like, wait, something is not good. The opening phrase of Hamlet, something is rotten in Denmark. Okay. So you begin to know. The other is carotene. We mistakenly think that folks of Asian descent have an abundance of carotene in their skin because it's yellowish. It really isn't. That is not the case. It does impart a certain amount of pigment in that regard, but again, it's mostly melanin related. If you did not know that. So, and again, it's a combination. So melanin made from our good friend tyrosine. You biochemistry fans, it's coming. Okay. Tyrosine's a big player. Thyroid hormone, okay. Epinephrine, norepinephrine. Tyrosine's a big player. So they are sent to shield and they protect DNA from ultraviolet light. The more sun, the more they protect, the more melanin. Different kinds, won't get into it. And so the amount and the form of the melanin. So these are local. When you have a freckle, more again, genetically, it's much more likely to have freckles than not. They're not in itself a problem. And moles are just isolated. It's when they begin to change that you have to be observant. And it's typically hard for the person and someone they know. When we were in practice, in the days before we had digital photography, we had little Polaroids that we would take. You saw something, I'm a little concerned about the skin. You take it, you have a little ruler next to it for size, see if it grows, because that gives you context. Snap a picture, stick it in their chart. Because we had paper charts. That's the way you did those things. So that's all of it. Excessive exposure to skin, to that, fibrous clump, leathery, I was telling you about that. Depress immune system and cause alterations. That's what happens. That's sunlight. Okay. If you don't protect from it, you're going to provoke changes in the DNA. Ultraviolet light destroys folic acid. And we have to ingest folic acid. We don't make it. We don't have a pathway. Bacteria have a pathway. We don't. We have to ingest it from our diet. And so as you can see there, photosensitivity happens and a lot of things. And photosensitivity, some people think, oh, it means it's a rash. No, that can be part of it. I mean, sometimes you'll go out in the sun after taking an antibiotic, and it's like, I can't stand it. I feel like everything's burning up. You run back in. My mom had that to sunlight. She could very, very hard to tolerate. But and there's certain things there you become acquainted if you go into a field. Perfumes can sometimes cause it. Anything. So you always think about it. Here's the carotene, palms and soles, where if anything it accumulates. Okay, and again, you convert it to vitamin A, which is important. So we get it from foods that are rich in vitamin A. So you'll eat carrots and it'll improve your vision. But generally, you can find vitamin A in a variety of foods. And here's the hemoglobin one. Caucasians, more transparent, so the color of hemoglobin shows through. And these are things that definitely have problems. When you're not getting enough oxygen, cyanosis is a pale, dusky blue kind of a color. Not good. You see someone is cyanotic, big trouble. You got to start to work. You better get going on them right away. If that color starts to change like that, we begin to see that in extremities with respiratory problems. They get things there. You can see there's almost a hint of a blue color, and we get thickening of fingers and toes. Little things you look at. Pallor, pale, anemia, number one inquiry. You cannot imagine how much anemia I had. We'll talk about it when we get to the blood. That's more about physiology. I mean, to the point where I will tell you about it. But when we're talking about things like transfusions, I've had so much of other people's blood. See, I used to be not funny. I used to be normal. I'm joking. Blood doesn't do that to you. I was hoping to get athlete's blood, but it's still, again, my vertical leap is still a half an inch or less. Same jokes I've used before. That's why you're not laughing. You probably heard them. It's not this Friday afternoon shit. Stuff. Erythema, redness. Okay, typically I'd say redness is inflammation, probably foremost. Less so with hypertension. Allergy, certainly. And jaundice has to do with liver malfunctions. It can't process the breakdown of hemoglobin into heme and get rid of it. Black and blue marks, we get them all the time. It changes because the hemoglobin is oxidizing, and that's why you see different colors. It goes a myriad of colors. That's normal. And I mean, and there are different areas with insulin resistance, etc. We'll stop there so I can briefly go through hair on Monday, and thank you. Enjoy your weekend.